Hi and welcome to the e-module training for primary care medical officers in Selangor. This module is created to guide you in managing chronic obstructive pulmonary disease (COPD) in primary care. This narrating voice summarizes the slide presentation. You may click pause if you need more time to read the slides. This is the outline for the presentation. We will cover definition and overview of the COPD, diagnosis and initial assessment, management of stable COPD, health promotion and prevention, management of exacerbations, and one case study will be discussed at the end of the presentation. COPD by definition is a heterogeneous lung condition with chronic respiratory symptoms such as cough and dyspnea due to abnormalities of the airways which cause persistent airflow obstruction. The pathophysiology starts with chronic exposure to smoke or pollutants, together with host factors which later cause impaired airways and thus will develop clinical manifestations such as chronic respiratory symptoms. The most common respiratory symptoms are dyspnea and chronic cough and sputum production. The main risk factor for COPD is tobacco smoking, but other environmental exposures may also contribute. Host factors such as genetic abnormalities and accelerated aging may predispose individuals to develop COPD. COPD patients may experience acute worsening of respiratory symptoms called exacerbations. Global prevalence of COPD is around 10.3% with 3 million deaths annually. With increasing prevalence of smoking, the prevalence of COPD is expected to rise. This will cause significant economic burden globally. A number of systematic reviews and meta-analyses provide the evidence that the prevalence of COPD higher in smokers and ex-smokers compared to non-smokers, higher in more than 40 years old group compared to below 40, and higher in men compared to women. And next, we move on to diagnosis and initial assessment. The diagnosis of COPD should be considered if any of these clinical indicators present: progressive dyspnea, recurrent wheeze, chronic cough, recurrent lower respiratory infections, and history of risk factors as mentioned in this slide. Once diagnosis of COPD has been considered, spirometry needs to be performed. Differential diagnoses of COPD that need to be considered are bronchial asthma, heart failure, bronchiectasis, tuberculosis, and others as below. The slide also mentions on the suggestive features of each differential diagnosis. Spirometry plays important roles in COPD. It helps us to diagnose COPD, assessment of severity of airflow obstruction, and therapeutic decisions. This table shows the example of spirometry interpretation for other result classification. Spirometry also can help us to determine other obstructive airway disease such as asthma, restrictive airway diseases such as sarcoidosis and pulmonary fibrosis, and mixed obstructive and restrictive airway diseases such as cystic fibrosis and bronchiectasis. To interpret spirometry in COPD, we need to perform pre- and post-bronchodilator spirometry. Next, calculate the ratio of FEV1-FVC pre- and post-bronchodilator to determine the level of airflow limitation. If post-bronchodilator FEV1-FVC ratio is less than 0.7 and non-reversible, the diagnosis of COPD can be made. Once the diagnosis of COPD is confirmed, 4 fundamental aspects need to be determined to guide us on COPD management. The 4 aspects are severity of airflow limitation, nature and magnitude of current symptoms, previous history of exacerbations, and comorbidities. This slide shows the severity of airflow limitation according to goal grades using the FEV1-FVC ratio. To determine the magnitude of patient symptoms, we may use modified MRC dyspnea scale or COPD assessment test. Both assessments will require patients to answer a set of questions to help us to determine the severity of their current symptoms. As we can see from this slide, in 2023, GOLD introduced new classification according to the history of exacerbations. Group A and B remain unchanged, while Group C and D were combined into Group E. Choices of bronchodilators are also changed according to the new group classification. This slide shows the latest framework, which includes latest GOLD ABE classification. Next, I will explain on the management of stable COPD. It is important to first assess the symptoms and history of exacerbations as mentioned before we proceed to the management. Smokers need to be encouraged to stop smoking. The main treatment goals are to reduce symptoms and reduce risk. Both pharmacological and non-pharmacological interventions are important in managing COPD. This flowchart summarizes the management of COPD, which includes diagnosis, initial assessment, initial management, patient's review, and adjustment of intervention. To help us with the pharmacological treatment, it is important to classify patients according to Group A, B, and E, as I mentioned before. This GOLD classification will help us to determine which bronchodilator is suitable for the patients. In all, the choice of inhaler given should be individually tailored, depend on access, cost, prescriber, and patient's ability and preference. It is important to provide instructions, demonstrate proper inhalation technique, and recheck on technique at each visit to ensure adequate inhaler technique. Inhaler technique should be assessed to determine whether the current therapy is adequate. These are the choices of bronchodilators available. Choices of short and long-acting beta-agonists, choices of short and long-acting anticholinergics. These are the choices of combination of short-acting beta-agonists plus anticholinergics in one device, choices combination of long-acting beta-agonists plus anticholinergics in one device, and other medications as listed below. This slide shows common inhalers that are available in government health clinic in primary care settings. COPD patients need to have regular follow-up once started with pharmacological intervention. During follow-up, review patient symptoms and exacerbations episodes. If patients respond well to initial treatment, maintain the current inhalers. Next, assess inhaler technique and adherence to pharmacological and non-pharmacological approaches. And finally, adjust treatment according to dyspnea or exacerbations pathway. This slide shows the follow-up pharmacological treatment algorithm, which will help us to determine our further management during follow-up. Determine predominant complaints such as dyspnea symptoms or frequent exacerbations episodes to help us with which pathway that we can use. This is the example of follow-up checklist that we can use during patient consultation. Before initiating inhaled corticosteroids, a lot of factors may need to be considered as shown on the slide. ICS may be started if the patient falls into strongly favors use and favors use criteria. Do not use long monotherapy of ICS alone. LABA-LAMA ICS combination is more superior to LABA-ICS combination, and for patients with asthma features, treatment should contain ICS. When can we refer to tertiary hospital? We can refer to tertiary hospital when the diagnosis is in doubt, spirometry not available in our facility, new onset of core pulmonary, patient is indicated for long-term oxygen therapy, when there is rapid decline of FEV1, patients with underlying genetic predisposition, and when certain drugs not available. And now, we move on to the health promotion and prevention. Smoking cessation should be advised in smoking COPD patients. The 5 A's brief strategy can be very helpful as initial approach to smokers. As for vaccination, influenza, pneumococcal and COVID-19 vaccines are recommended for patients with COPD. Other vaccines such as Tdap vaccine and zoster vaccine are also recommended if indicated. Pulmonary rehabilitation improves quality of life and reduces hospitalization in COPD patients. Self-management intervention and good communication with healthcare professionals improves health status and decreases hospitalization as well. As for palliative, end-of-life and hospice care, opiates, neuromuscular electrical stimulation, oxygen and blowing air onto the face can relieve breathlessness. Nutritional supplement improve overall health status. Long-term oxygen therapy increases survival in patients with severe chronic resting hypoxemia. For long-term oxygen therapy, this slide shows the indications for long-term oxygen therapy in stable patients. Next, I will explain on managing exacerbations in COPD. Acute exacerbations by definition is characterized by dyspnea and/or cough and sputum that worsen over less than 14 days. Causes are by airway infection, pollution, and other causes. Relevant differential diagnosis should be considered. Short-acting bronchodilators are recommended as initial treatment. Maintenance therapy with long-acting bronchodilators should be started as soon as possible. Systemic corticosteroids can improve exacerbations and shorten recovery time. Metazantines are not recommended and non-invasive mechanical ventilation should be the first mode of ventilation in COPD patients. The slide shows the classification of severity of COPD exacerbations. According to the algorithm, patients with COPD need to obtain relevant history, examine for danger signs with appropriate investigations. Initial treatments such as oxygen therapy, inhaled short-acting bronchodilators, oral penicillin and antibiotics should be started if indicated. Failure to improve, patient needs to be referred to hospital for admission. Indications for hospital admission or assessment include severe symptoms such as worsening of dyspnea, acute respiratory failure, onset of new physical signs such as cyanosis, hemodynamic instability, failure to respond to initial management, presence of serious comorbidities, and insufficient home support. Antibiotics can shorten recovery time, reduce treatment failure, and hospitalization duration. However, antibiotics should be given to patients with at least 2 out of 3 cardinal symptoms and to patients with severe COPD that requires invasive or non-invasive ventilation. For COPD patients, follow-up should be given within 8 weeks after discharge. The following should be assessed, such as ability to cope in usual environment, spirometry measurement, inhaler technique, understanding of current treatment, smoking status, need for long-term oxygen therapy and home nebulizer, suitability for pulmonary rehabilitation, vaccination, and self-management plans. Next, we will discuss a case study on management of COPD. Patient Encik J is 72-year-old male. Your pharmacist has informed to you that this patient has been using MDI Brodua frequently since last meeting. He has underlying hypertension, dyslipidemia, and COPD. His COPD was diagnosed more than 5 years ago in tertiary hospital. He has stopped smoking 3 years ago. Currently, he is on MDI Brodua 2-puff PRN, and other medications for hypertension and dyslipidemia. On further history, he feels more breathless for the past 2 years when walking from one room to another room in his single-story house. He has productive cough with whitish sputum. He had one episode of nebulization in the past 1 year at GP. Otherwise, he had no history of hospitalization, no constitutional symptoms, and no failure symptoms. He has intermittent pedal edema after prolonged standing. Upon further questioning, he uses MDI Broadwell 3 to 5 times daily, but his breathlessness still not relieved. He was previously prescribed with MDI Foster in hospital, but he preferred not to continue with MDI Foster due to the aftertaste. What further assessment that we need to proceed with this patient? As mentioned before, the choice of inhaler need to be individually tailored. We should discuss with the patient about his preferences on inhaler and our inhaler's availability. MDI technique should be assessed and possible triggers should be explored for this patient. Other differential diagnoses such as heart failure, tuberculosis, anemia, lung cancer should be considered. Upon examination, patient looked comfortable, pink, not tachypneic and no finger clubbing. Lungs are clear, heart auscultation, low rhythm, no murmur, no pedal edema, vital signs are normal. Chest X-ray findings are hyperinflation with cardiomegaly. Recent blood investigations such as full blood count, renal profile, liver function test and thyroid function test are all normal. ECG shows sinus rhythm with no ischemic changes. Sputum AFB times 3 was done and negative. Echocardiogram was done with ejection fraction was 58%, no regional wall motion abnormality and mild tricuspid regurgitation. After all other differential diagnoses have been ruled out, this patient was then started on Respirto Respimat, a LABA-LAMA combination. During follow-up in 2 months, his cough much improving and able to walk further than usual. He was then advised for COVID-19 vaccine booster, pneumococcal vaccine and influenza vaccine. Finally, these are the references used to create this module. Thank you for joining this module and hopefully this module can benefit us in managing COPD patients in primary care. Thank you and goodbye.